Well, good morning, everybody. I'm Tim Beebe, the Interim Dean for the School of Public Health, and I'm delighted to welcome you all to our 14th Annual Research Day. We're just talking about that, the fact that, this is probably our second or third year in a row we've had to do this virtually, and we all collectively wish for a more in-person version of this next year. But I'm very glad to see everybody here today joining in this wonderful event. But before I start, I want to acknowledge that the School of Public Health at the University of Minnesota is built within the traditional homelands of the Dakota people. It's important to acknowledge the peoples on whose land we live, learn, and work as we seek to improve and strengthen our relations with our tribal nations. We also acknowledge that words aren't enough. We must ensure that our institution provides support, resources, and programs that increase access to all aspects of higher education for our American Indian students, staff, faculty, and community members. All right, so again, I want to thank you all for taking the time this morning to participate in this annual showcase of our student faculty research within the school. As a Carnegie R1 Research University, research is a pillar of our mission, and it's important to celebrate the innovative and emerging work being accomplished within our school. Public health is and always will be essential to preventing disease and injury and to promoting health and wellness in whole communities and populations. Our school's innovative and collaborative research responds to today's most pressing challenges and shapes the health of populations and communities into the future. This is a critical obligation of our land-grant university mission to our state, nation, and all the partners with whom we collaborate at home and around the world. At the School of Public Health, we know that our success today and in the future relies on our ability to produce world-class research that can be translated into meaningful action. And that's a hallmark of our land-grant mission, translating research to practice and policy. 78 years ago in 1944, a little bit before I was born, we were founded as the 7th School of Public Health in the United States. Since that time, we've been at the forefront of public health research and education and are regarded as one of the premier public health research institutions in the world. I'm proud to say that our school ranks number 6 in NIH funding among schools of public health, and we hold the second largest research portfolio at the University of Minnesota. It's important to remember that even though we just recently slipped out of the top 10 in terms of ranking, we're still within the top 5% of accredited public health schools and programs in the country. So we're known around the globe for our work in preventing and combating infectious disease outbreaks, fighting obesity, reducing the global cancer burden, keeping workers safe from illness and injury, and developing leaders who will run clinics, hospitals, and entire healthcare delivery systems. And we've gained a broadening reputation for dismantling structural racism and systems of oppression. Now, more than ever, a sense of urgency is pushing us to look forward. And now is the time to deepen and strengthen our research portfolio so that we're prepared to tackle these challenges far into the future. It is with this imperative in mind that we convene today to pause a bit, something that we've done too infrequently these last 2 years, and celebrate our tremendous research and the impact of our faculty and students. So now I'd like to introduce our wonderful colleague, Dr. Marizan Ramirez, who will be emceeing today's event. Beginning in March 2021, I'm sure it seems much longer to her, Marizan will assume the role of Associate Dean for Research. So she is marking her first year in this role. Congratulations for surviving that year. She's a professor in our Division of Environmental Health Sciences. She currently directs the Midwest Center for Occupational Health and Safety and serves as Program Director for the Occupational Injury Prevention Training Program. Her own area of research focuses on injury and violence prevention in marginalized populations. She has developed and evaluated a number of public health prevention and intervention strategies and is committed to using epidemiological methods that advance the field, as well as patient and community engaged strategies to build community research partnerships. So now I'll invite you to join the screen.
Thank you so much, Tim, for the wonderful, wonderful introduction. So before I begin with my short remarks, I just want a little bit of interaction with our audience today. I would love to know, for our students, share with us one fun fact that you learned in your class this year, some fun research fact. So if you all don't mind, go type that into the chat box because I'd love to learn what are you learning in your classes. So we'll wait a few minutes and wait and see what pops up. Are we having some shy people out there? All right, well, we'll wait. I would love to hear what you're learning. As folks are populating the chat box, I just want to say a few words. One of my first tasks in my role as Associate Dean for Research was to develop a strategic plan, which is taking shape now and includes 3 aims and over 100 key objectives. Now, that sounds like a daunting task, but they do really fit under this big mission that, number one, we really want to elevate their School of Public Health prominence as a research powerhouse. And today allows us just to do that. As Interim Dean Beebe highlighted, we rank highly in NIH funding with more dollars awarded this year than ever before, and including the most highly NIH funded researcher in the nation, Dr. Jim Neaton, who is from the Coordinating Centers for Biometric Research. Our research enterprise is highly prolific, with approximately 90% of our grants submitted last year being funded. The majority of our grants come from NIH, but also come from other agencies like CDC, AHRQ, business and industry, foundations, and with other university partners. Our awards of the past 3 years were from 30 different granting mechanisms. We currently have 550 awards in progress with 241 initiated in the last year. That's a lot going on in our institution, and we have so much to be incredibly proud of. The kinds of research that we address really cross so much topics across entire age and developmental lifespan, from rural to urban, from the issues of our time, such as anti-racism, emerging workforce needs, the impact of climate change, COVID-19, and much, much more. So today's presentations just provide a sample of our research portfolio and scholarship reflecting our diverse and innovative research being conducted across our school. So we've got a couple of comments about things that folks have learned. Lisa Hunwardson learned that I really have to be careful with how I look at data. There's a lot of research out there to examine, but not a lot on occupational health nurses. Lisa, thank you so much for sharing that information. We've got another in our Q&A. We have an attendee said, I learned a lot about the healthy immigrant effect. So really wonderful things that are happening in our school, new things that we're learning each and every day. So I thank you all for coming today, hearing from each other, learning from each other, and growing. So with that, I think we are going to go and get started with our lightning round presentations. So we have 8 lightning round speakers presenting their scholarship. 6 are faculty and 2 are PhD students. We highlight 2 speakers from each of our 4 divisions: biostatistics, environmental health sciences, epidemiology and community health, and health policy and management, to convey the spectrum of our research portfolio. Our plan is to listen to each speaker's presentation, then hear our student poster first place winners presentation, and learn from other student poster winners. Then we'll take the time towards the end for questions and answers. So if I can ask anyone who has questions, please either enter them into the chat or the Q&A box, and we will keep track of them. So I'd love to get started, and I'm pleased to welcome our first speaker today to the screen, Dr. Dana Carroll. Dr. Carroll is an assistant professor in the Division of Environmental Health Sciences, and her topic is a potential approach to averting 8.5 million deaths by 2100. Dana?
Thank you, Marison, and welcome everyone. As Marison mentioned, I'm going to be talking about a potential approach to averting 8.5 million deaths by the year 2100. So this graph here shows the average daily deaths in the United States during 2021. What we see as the top 11 leading causes of death, that heart disease and cancer rank at number 1 and 2. What do we know about heart disease and cancer? Well, about 25% of heart disease related deaths are due to cigarette smoking, and 40% of cancer deaths in the United States are due to cigarette smoking. I want to highlight that cigarette smoking is a social justice issue. If there's one thing you leave with my presentation, I think that is this. Social justice issues are ones based on equality and human rights. It's the idea that everyone, regardless of circumstance, should have equal access to health, opportunity, and the privileges that society offers. One of the major barriers to achieving social justice is commercial tobacco use. For decades, the tobacco industry has purposely and disproportionately targeted specific populations. These populations include African American persons, American Indian persons, the LGBTQ community, and individuals of lower socioeconomic status, leaving these groups to suffer the negative health consequences related to commercial tobacco. For people who smoke and those around them, they watch their families get sick, lose their income to cigarettes, and tragically die earlier. Public health, including our school, is trying to improve prevention and cessation around commercial tobacco. In fact, much of my work that I get to do is to work alongside American Indian communities to develop more effective smoking cessation programs. And this work is helping move the needle to reduce commercial tobacco. But what if we took another approach? This is a famous quote by Professor Michael Russell. People smoke for the nicotine, but they die from the tar. So what would happen if we removed or dramatically reduced nicotine in the combustible cigarette? For some context, there's about 15 milligrams of nicotine per gram of tobacco in a cigarette, if you went out and bought that at a store today. What if we reduce this to a very, very low level, about 0.4 milligrams of nicotine per gram of tobacco? It would be important to know that this approach would mean that all tobacco manufacturers would be required to only sell these cigarettes in the United States. So you go out to the store, Marlboro, Newport, Camel, Pall Malls, whatever brand of cigarette available in the store would only have very low levels of nicotine. Is this possible? Well, in fact, in 2009, when Obama was in office, he signed into law the Family Smoking Prevention and Tobacco Control Act. This gave the authority to the Food and Drug Administration the ability to regulate commercial tobacco products for the benefit of public health. What we do need to do, though, is provide the science base to the FDA on how to regulate tobacco products in a way that will improve public health. And this is a very interesting and exciting area of research with potential large impacts. What we know about very low nicotine cigarettes comes largely from my colleagues, Dorothy Hatsukami here at the University of Minnesota and Eric Donnie at Wake Forest, as well as some studies by myself. We know that use of very low nicotine cigarettes in clinical trials leads to reductions in cigarette smoking, lower dependence on cigarettes, increased quit attempts, and more smoke-free days. Because overall, again, people smoke for the nicotine. This approach in modeling has shown that could reduce the prevalence of smoking in the United States to less than 2%. For context, it's around 13% as of right now. And averting cigarette-caused death by 8.5 million by the year 2100. A profound potential public health impact. This is on the radar. The FDA announced in 2017 a comprehensive plan for tobacco and nicotine reduction due to some of the research by my colleagues and I. Now the question is, how can we assist people who smoke with this approach? If this approach were to happen, we do not want to leave people behind who are already currently smoking, but to meet them where they're at, to assist them with making this approach more palatable. One area of research is to make sure that we're offering smoking cessation resources for quitting and potentially assist those who still need or want nicotine to shift to other non-combustible commercial tobacco products. So while complete cessation of all commercial tobacco is the goal, another potential approach would be to shifting people down this continuum from commercial cigarettes to non-combustibles and ideally nicotine replacement therapy, with the ultimate goal of cessation of all commercial tobacco products. So this is some ongoing research that we're doing right now, seeing how folks that get low nicotine cigarettes, what are they doing in terms of using other commercial tobacco products. Another important area of development and research is we must learn how to communicate in advance about this standard to the public. The public would need to know that nicotine is being lowered in cigarettes if this approach were to happen. And I have the opportunity through the resources, through the School of Public Health, and through my collaborations to contribute to this area. I have a current ongoing clinical trial exploring different ways of messaging on low nicotine cigarettes. And we've identified that messaging such as these cigarettes may make it easier for you to quit, will be less addictive, but can still be as deadly as normal cigarettes is one way to communicate this low nicotine standard in a way that's beneficial. I want to highlight my team here of students from the School of Public Health that I have the opportunity to work with on my different studies. We have Mackenzie, Maria, Andy, Julie, and Anna. So thank you so much for your attention, and I look forward to answering questions during the Q&A.
Thank you so much, Dana, for a wonderful presentation. And we are now going to go quickly to our next speaker today. And I'm pleased to introduce Dr. Ryan Demner. And he's an associate professor from the Division of Epidemiology and Community Health. His topic is challenges to understanding post-acute sequelae of COVID-19.
Thank you, Dr. Ramirez. Good morning, everyone. It's a pleasure to be here. I'm going to spend the next few minutes talking a little bit about post-acute sequelae of COVID-19, or PASC, which is also frequently referred to as long COVID in the media. PASC is an increasingly important entity at this point in time, as now over half of the global population has been infected with SARS-CoV-2. And it really requires us to direct a lot of attention to what the long-term chronic outcomes may be from this infection, in addition to the short-term acute outcomes. The definition of PASC at this moment in time varies quite a bit depending on the context and the agency with which you're dealing, but it generally refers to the presence of at least one health problem that is either new, recurring, or ongoing at least 1 month after a SARS-CoV-2 infection. This is one example that you see from a table in a recent publication looking at the possible spectrum of PASC. And don't get too caught up in the details. The point is that it's dizzying in trying to track it all. Essentially, if you have a sign or symptom that you're interested in studying, somebody has probably considered it as an effect or the result of COVID in the context of PASC. And not included on this particular table were neurologic outcomes, including cognition and sensory defects, as well as GI conditions that have been frequently reported following COVID as well. Next slide. So while it might seem very unlikely that what we commonly view as a respiratory infection or a respiratory virus can have wide-ranging systemic effects, there are actually examples from many other infection models that suggest this is possible. And data on SARS-CoV-2 are accumulating to support the biological plausibility of these system-wide effects. So this figure here is a heat map. In the rows represent different tissues across different end organ sites in the body, and the columns represent a subset of individuals who are autopsied following death from SARS-CoV-2. And the upshot here is that wherever you see color, that means that SARS-CoV-2 is detected, and often in a form that could replicate. They found that SARS-CoV-2 was widely distributed throughout the body, including many sites in the brain, including in asymptomatic and mild infections and up to 9 months following infection. Next slide. In terms of the prevalence, this is a summary of about 57 studies from 250,000 individuals. And on average across studies, over half of individuals with a prior infection were experiencing at least one symptom all the way out to 6 months. Next slide. So the initial research on the concept of PASC is suggestive, and for many outcomes, it's not at all surprising that SARS-CoV-2 was likely the cause of those outcomes. But for others, there are many limitations. And in terms of the big picture of studying PASC, we could talk literally for days about limitations in the current research that is ongoing. I want to focus on highlight just one particular limitation, which has to do with getting good and highly valid definitions of infection if we're going to study SARS-CoV-2 as an exposure for chronic outcomes. And particularly, we need to think of ways that can identify mild or asymptomatic infections. Next slide. So with that in mind, antibody testing is actually a very nice possible solution. Antibody testing has not been very useful in terms of diagnosis and for clinical utility, but in a research setting for these purposes, it could be quite useful. It's a good confirmation and validation of self-report data. It can help us identify undiagnosed, asymptomatic, or polysymptomatic individuals, and it's an objective measure. Of equal importance is the fact that it could capture infections several months prior. So that makes it very efficient in terms of capturing and defining exposure in longitudinal cohort studies. And it could offer some insights into the immunophenotype and more nuanced exposure constructs. Next slide. I want to say two quick things about antibody tests. So two commonly used antibody tests are available. One targets the spike protein. And what's important to know about that is it's reactive to both infection and vaccination. So it's not very useful in a highly vaccinated population to identify prior infections. On the other hand, there are anti-nucleocapsid protein assays that are reactive to infection, but not vaccination. And a group from our school has generated some data showing that they do quite well at identifying prior infection in the context of vaccination. But in terms of these assays, we still have limited knowledge about how long people are reactive and phenotypic predictors of response. Next slide. So the final slide I want to show here gets at this issue of how long after an infection you might remain positive in these antibody tests. These are 53 individuals enrolled in a study, and these 53 individuals were assessed up to 4 times with an antibody test, a nucleocapsid protein. And the triangles represent individuals who were antibody negative, and the circles represent individuals who were antibody positive. And keep in mind, we knew from prior studies in this group that all 53 had been previously infected. And the upshot is that less than half of them at about 1 year post-infection remained positive to this assay. And the gray plotted points represent individuals who were asymptomatic or had mild symptoms, at least didn't know they were infected. So it appears in these preliminary data that the people who were asymptomatic were the most likely to test negative. Confirming findings like this and improving the assays or the timing in which they're delivered to better capture exposure status so that it's not variable by symptomatic status will be really important. And this slide highlights that. Next slide. So in conclusion, studying chronic COVID outcomes is becoming increasingly important. There's strong early suggestion that COVID-19 could have long-term implications system-wide. And we need to develop better tools to understand infection as a dynamic and rapidly changing exposure construct. Thank you.
Okay, thank you so much, Dr. Demer. I'm pleased to introduce our next speaker today, and that is Ms. Mary Kosuth. And Mary is a doctoral student in our Division of Environmental Health Sciences. She will be speaking on the immortal plastic bottle, the scope and fate of microplastic contamination. All right, Mary.
Thank you. So I'm here, we can advance the slide. I'm here to talk about something we think we know very well because we grew up with it. It actually made our lives easier. I dare say it even brought us joy. Regrettably, I'm here to tell you that this thing that we thought we knew very well actually leads a secret double life as an environmental contaminant. Advanced slide. Of course, I'm referring to plastic. For those that don't know, this is a scene from a movie called The Graduate. Here, Dustin Hoffman, a young man just out of college, is being pulled aside by his parents' friend and told that an incredible and prosperous future can be found in plastic. Advance. It's a funny scene because the first true synthetic polymer was developed 60 years before this film debuted. Next. So this would be like pulling your friend's kid aside and in a conspiratorial whisper telling them that there's an exciting future in computers. Suffice it to say, plastic wasn't new in the 1960s, unless you're a marine ornithologist, because that's when plastic pollution made its first debut in the guts of seabirds. After 45 years of research in marine habitats, scientists discovered plastic refuse in fresh water. I put that in air quotes because I put the word discovered in air quotes because it's just like that scene from The Graduate where science is the parent friend pulling us all aside and telling us something true, but also embarrassingly obvious. Around this time, there were also over 100 papers showing plastics in seas and oceans, but it took a minute before someone exclaimed, wait, we eat things out of the ocean. So in 2015, the testing of human food and beverages commenced. This is also when plastic was discovered in ambient and indoor air. Most recently, plastics have been extracted from human bodies. This 10-micron shard was recovered from placenta. 2 weeks ago, plastic bits were found in drawn blood, and last week it was found deep in lung tissue. Presently, there are more questions than answers. Here in environmental chemistry, the life cycle of plastic is an area of intense interest. For example, how do pre-industrial resin pellets like these transform into a chip of polyethylene scavenged by snow in my South Minneapolis backyard? Globally, 40% of all manufactured plastic is used in packaging, but how does this break down? What are the mechanisms and rates of degradation? What are the routes of transport? How far can it travel? Will it eventually be sequestered? In order to understand the enigmatic life of plastic, improving methods of detection is central. In our division, locally purchased salt, regional beer, global tap water were all tested and results published in 2018. Pilot studies involving other consumer products have also been carried out. Since a fair amount of plastic is passed through wastewater treatment, we're also working on developing mitigation techniques. However, wastewater treatment plants are rather good at what they do. About 1/10 of plastic particles, less than that, is actually washed out in the effluent. So the remaining 90% settles into the sludge, which can be applied to agricultural land. This means worn particles can be reintroduced into the environment and possibly washed from land into bodies of water or carried off by wind. For this reason, our lab extends to the 8th floor rooftop of the Mayo Memorial Building, where both passive and active air sampling affords us the opportunity to study morphology, size, chemical composition of plastic particles in order to understand what settles and what remains aloft. Finally, through some exciting international partnerships, we have an opportunity to look at long-range transport in water samples from the Canadian High Arctic. Of course, this is not a comprehensive schematic. The intention here is simply to highlight some of the frontiers of microplastic research that our division is exploring. Looking into the future, the near future, I believe a better understanding of this contaminant will come from a more interdisciplinary One Health approach. For example, the aforementioned work involving human exposure and health intersects with plastic's ability to leach additives and sorb environmental pollutants. Go ahead and show those chemical compounds, and sufficiently small contaminated particles can be ingested by zooplankton or even taken up by terrestrial plants. This obviously carries implications for wild-caught and domestically reared human food sources, but it also impacts animals such as the snake, fatally entangled in some erosion control netting here in Minnesota. And there's one more picture there. And we'll go to the last slide. My closing thoughts on this topic are at the end, not because they're the least important, but because they're the most important. The vast majority of plastics are derived from fossil fuels, inextricably linking this contaminant issue to climate change. Approximately 4% of fossil fuels are used to make plastic, and another 4% of fossil fuel energy is required in manufacturing. And all future industry projections show growth in global plastic production. We must acknowledge that the extraction and refinement of raw materials, the production and manufacture of plastics, and the disposal of waste accentuates existing environmental and health disparities, placing a disproportionate burden on poor and disenfranchised communities. We ought to be centering and engaging with these communities as we think about ways to solve this problem together. Thank you for your time. It's such a privilege to be invited to share this work.
Thank you so much, Mary, for a really wonderful, engaging presentation. Our next speaker is Sidney McGuire, and Sidney is a doctoral student in the Division of Health Policy and Management. So now we will look at health and political participation, a cycle of inequity.
Thank you, Marizan. Hello, everyone, and thank you for having me here. Today, my talk will be about health and political participation, my work in this area, and future areas of research for myself and other scholars on this topic area. So some of you may know that there's a growing body of literature which demonstrates that individuals in poorer health are less likely to turn out to vote, as seen in this graphic from Pacheco and Fletcher's 2015 paper. Amongst scholars, there are two predominant hypotheses to explain why this may be happening: the health gap hypothesis and the politicization hypothesis. The health gap hypothesis assumes there is a positive relationship between a person's health and the quantity of their political involvement. So the idea is that if someone is more healthy and they have more physical, cognitive, and social or emotional resources, this may promote more participation. While the politicization hypothesis assumes that the experience of health issues, illness, or disease patterns may produce a shared experience or social identity, which may produce more participation. I and other scholars think this is part of a larger negative feedback loop whereby disparities in health among individuals leads to inequitable access to voting, thus creating disparities in political participation by health status. And when I say political participation, I mean several ways people can participate: voting, attending a political protest, march, or demonstration, volunteering for a campaign, or contacting a politician. And so these disparities in participation by health status results in leaders who are less responsive or possibly not responsive at all to the non-participating constituents, thus producing more policies which impact health inequitably, ultimately leading to disparities and inequities in health at the community level. Next slide, please. I started investigating the relationship between health and political participation during my first year here as a PhD student. And I saw that we didn't know a lot about it. We don't know what the relationship is between health and other forms of political participation, which are not voting. And then I also became interested in whether this relationship varied across income levels. And I became very interested in investigating racialization and racism, because I know there are so many inequities in health impacting the health of Black communities. Then, as I thought about health inequities, I wanted to know whether health inequities at the community level may be impacting individuals' likelihood of political participation. Next slide, please. And this leads me to these larger overarching questions and implications driving my work. How does this impact whose voice is heard in politics? How does this impact our ability to achieve population health equity? So I conducted a few studies to begin investigating the relationship between health and political participation in different ways. Next slide. So this first paper I began working on in this area uses data from the Behavioral Risk Factor Surveillance System to examine associations between diagnosis with a chronic health condition and likelihood of voter turnout in the 2012 presidential election. We found a notable new relationship between diabetes and voter turnout. You can see at the bottom of your screen that individuals who reported diagnosis with diabetes had a predicted probability of turnout of about 75% compared to those who reported never being diagnosed, who had a predicted probability of turnout of about 69%, which was about average. So we can see from this that the experience of living with diabetes may impact likelihood of voter turnout in 2012. So this evidence could support the politicization hypothesis, but more research is necessary. Next, I'm going to show you some of my current work from my dissertation. Next slide. So for my dissertation, I wanted to examine the relationship between political participation and health at the community or ecological level. And I wanted to investigate different forms of participation. So what you see here are results from a study I conducted using the Robert Wood Johnson Foundation County Health Rankings, which has measures of health at the county level, merged with the Cooperative Congressional Election Survey, which has measures of individual level political participation. And this figure shows you the marginal effects of each county level explanatory variable on the likelihood of individuals attending a political protest, march, or demonstration in the last year. And this would have been over the course of 2018. And so you can see here that there are several factors associated with likelihood of protesting in the past year using this data. And next, I'm going to show you how this relationship breaks down by race, and we'll just go over it really quickly here. Next slide, please. So here you can see among those who are racialized as white, there are several factors which are positively associated with likelihood of protesting. And those are severe housing problems, violent crime, excessive drinking, and poor mental health days. And there's a negative relationship between protesting and smoking at the county level. Next slide, please. And so now I'm showing you the average marginal effects of protesting among those who are racialized as Black. And here you can see there are several significant and negative relationships between protesting and violent crime, air pollution, and BMI. So this work suggests that there is a relationship between health at the ecological level and political participation, and that this relationship varies by racialization. Next, I will wrap up by discussing the future agenda of research in this area. So we definitely need more research on health and other forms of political participation, other dimensions of health. And my work was specifically focused on politically marginalized and systematically underrepresented populations. I'm really interested in how racialized health inequities may be connected to racialized disparities in political participation. And we need to move forward past identifying associations between health and political participation. And two ways to do that may be quasi-experiments, where research can examine quasi-exogenous health shocks to either people or communities. And then also simulation modeling, where we can use micro-simulation models to model counterfactual conditions to try to understand how different groups' political participation outcomes would differ under various circumstances. Next slide, please. So thank you so much for listening to me talk about my work today. My work is funded by the NIH, the Minnesota Obesity Prevention Training Program grant, and also the doctoral dissertation grant. Thank you.
Thank you, Sidney, for a really wonderful presentation on a fascinating topic. So we will stay in the Division of Health Policy and Management. And now we will hear from Anka Kimbang, who is an assistant professor in HPM. Her title of her presentation is "I Didn't Really Fully Understand Until I Came into the States: African Immigrants' Introduction and Awareness of Dementia." Anka?
Hi, good morning, everyone. Thank you so much for having me today. So I would like to start by thanking the organizations and different groups that have funded our work today, without which the work would not be possible. Next slide, please. And so I'm going to talk about our work that is related to memory. And this work, in the past year, we actually came up with this theme, which is now the Immigrant Memory Collaborative. And this work started out with our community partner coming to us as researchers at the university saying, we're seeing some sort of memory loss and dementia in the community. Can you all work with us to identify what's happening? And so that community partner was ACER, African Career Education and Resources, Inc. It's a nonprofit in the northwest suburbs of Minneapolis in Brooklyn Park. And so we worked with that community partner at that time to apply for funds, and we started the African Immigrant Memory Loss Project. And that project was really answering the question that they approached us with, which was to understand the needs, resources, and assets in the community related to dementia and memory loss. And an outgrowth of that project, which was based on findings, was the Dementia Education Project. And that project, we're going further to develop a culturally tailored dementia education project. Dementia education for and with the community. And so this work has a trifold kind of leadership model. All our work is guided by the University of Minnesota research team and staff. We have the ACER staff and interns, and then both of the projects, so all our work has project advisory boards, and we all work together. And the project advisory board members are community members, caregivers, advocates, healthcare practitioners, and they really help guide and lead us as we engage in this work. Next slide, please. And so the methods that we're using, we use a diverse approach or diverse methodology. We have project advisory board meetings and we take notes at those meetings. We hold community conversations and focus groups. We have implemented surveys in the community. We have key informant interviews. And then for our data analysis, again, we're using both qualitative and quantitative methods, including thematic and content analysis. Next slide, please. And so a little bit about some of what we've found so far is that there's really no dementia relevant words in many African immigrant languages. And so we find that there's no word for dementia. And the word or the things that loosely translate to dementia in many African immigrant languages are typically related to mental health. And oftentimes it's not positive mental health, it's negative. And so you're either crazy, you're forgetful, you've been bewitched, or those kinds of things. And then we also find that there's no word or relevant word for the kind of the function of the caregiver. What we typically consider caregiver in the United States is very different. And so in many African immigrant countries and contexts, the caregiver is just known by the relationship that they have to that person. So if you're caring, your husband providing care for your wife, you're providing care for your wife, and the husband will never typically consider themselves a caregiver. And it's even interesting that whenever they hire kind of some other support person to come in and provide care to a person living with memory loss or dementia, they actually would say that we hired somebody to help dad or mom care for the person living with dementia, but that person is also not considered a caregiver themselves. Next slide, please. And then going on what we found related to cultural beliefs, we found out that culture is very important. And in the African immigrant countries and culture, care is typically provided in the home and is often provided by a relative or family member. And this is something that a lot of the participants and the persons in our community conversations and various data that we have stressed that they want care provided by a family member and the one care provided in the home, which is very different for many of the persons living with dementia in the United States who are typically cared for at the facility level. Next slide, please. We also find that there's quite a few challenges related to dementia and memory loss in the community. The first one is that many people did not know what dementia or memory loss was in their countries of origin. And so they began to recognize what dementia was, or that dementia was a medical problem, when they migrated to the United States and started working in a healthcare related job, which also means that people who have never worked in a healthcare related job might actually really not know what dementia is, which is why there's such a limited understanding and limited knowledge about dementia in the community. We also find that with mental health in general and kind of dementia, there's a lot of stigma surrounding it. And so there's a need to kind of think about how do we destigmatize this condition so that we can provide and bring in resources into the community. Next slide, please. And we also find that the community has been very resilient. Despite all of the challenges that people are facing, the community has also developed a lot of resources that they're helping persons living with dementia. The first one is that there's been an outgrowth of kind of different types of facilities, like an adult day service program that is created for, and it's run by African immigrants for African immigrants, persons living with dementia and other medical problems. We also find that there are other support groups that have been developed, like the quote to the far right talking about a support group program that was developed for Liberian immigrants in the United States, and that they go and they meet every week on Wednesdays to really talk and help each other deal with their medical problems. And then the other kind of resource we found in the community is that there's a lot of education that is being provided by various African immigrant community organizations. So they'll have nurses organizations, they have doctors, they have different groups that have come together to really develop different education programs that are being delivered into the community and with the community. Next slide, please. And so what we're doing right now is developing an intervention for the community, and we also have a grant out to do further specific or kind of tailoring of interventions for the community. But what we've found is that building community is very essential, that this work cannot be done by researchers alone. It cannot even be done by just one community partner. And so what we're doing as a group, including a current community partner, a project advisory board, is really coming together to develop collaborations, which is why our work is now titled the Immigrant Memory Collaborative, because we're coming together as a collaborative to begin to build community that is going to help us really get into the community and deliver tailored interventions for the community. Next slide, please. And I just wanted to thank you all for listening today, and I look forward to the questions that you have during the Q&A session. Thank you.
Thank you so much, Manka. Really fascinating work, especially with your community partners. So look forward to chatting more about that during the Q&A. So now we will move over to the Division of Biostatistics, and I'm really pleased to introduce Sandra Sappho, and she's an assistant professor in the division. The title of her talk is The Promise of Multi-View Learning in Public Health Research. Sandra.
Sure. Hi, everyone. Good morning. I'm excited to be here. Today, I'll be a salesperson trying to sell you a product. And that product is systems biology or data integration. So I'm going to attempt to convince you on why you should consider collecting data from multiple sources in your next research work. So when I say multiple sources, I'm referring to data, let's say genomics, proteomics, metabolomics. It could be imaging, in addition to electronic health records data. So many diseases are complex, heterogeneous conditions that affect multiple organs in the body. And they depend on the interplay between several factors. So genetic, environmental, cellular, and molecular factors. But then the diagnosis and treatment of these diseases are mostly based on symptoms or on a single measure. It is therefore not surprising that the pathogenesis of complex diseases remain elusive and that therapeutic targets are lacking. So let's take an example, adult heart failure. This is a chronic disease, progressive disorder that affects more than 6.5 million Americans in the US. It is currently often categorized using just a single metric, and that metric is ejection fraction. But then heart failure is a multi-organ syndrome that has many related yet seemingly disparate phenotypes. So the NHLBI, recognizing the need to shift from the use of just a single metric, in 2022, organized a heart failure challenge that was aimed at using data from multiple sources to redefine heart failure. And this is not just specific to heart failure. It is also specific to multiple diseases. So the typical approach of diagnosing or treating diseases that focuses on a small number of molecules or on a single metric or on a single type of data cannot fully address the complexity and heterogeneity in complex diseases. While genetics have identified genetic variant, most of these functions have not been determined. So there is the need to integrate data from multiple sources. There is a need to combine, for instance, metabolomics, which are chemical reactions in the body, with genomics to identify biomarkers that could be used to treat diseases. So integrating data from multiple sources. One, we can identify non-invasive biomarkers that can improve clinical decision-making and could serve as therapeutic target. We could also better understand the interactions between the environment and the molecules that affect health. We could also have novel ways to define disease subtypes and endotypes based on molecular signatures. And it could also enhance clinical trials by providing targeted ways to develop and test personalized treatment in specific patients. So I hope I have convinced you on why you should consider data from multiple sources. So then if you're able to collect data from multiple sources, you have to ask yourself, how do I make sense of these multifaceted but related data types? And now enter our research group. So our group is developing a suite of novel, robust, and powerful statistical and interpretable machine learning methods for integration and interpretation of cross-sectional and longitudinal data from multiple sources. So we are using deep learning methods, statistical machine learning methods, enrichment analysis. We're considering bunch of simulations so that we could better predict diseases. We could better identify, or we could identify disease subtypes and endotypes. It would help us provide greater insight into disease mechanism, and we could identify target for therapeutics. Next slide, please. So let me take an example, coronary heart disease. So coronary heart disease is a very common disease in the US. It affects more than 3 million people in the US a year. So there are about 3 million cases in the US every year. The direct and indirect cost of CHD is high, and it creates a large economic burden for the US healthcare system. CHD is a multifactorial disease. So we have established risk factors that we normally know: age, smoking, LDL, and many other factors. There is also genetics. A lot of genetic variants have been identified that cause CHD. There is also emerging factors like inflammation. Research suggests that established risk factors, so these traditional risk factors, account for less than 50% of CHD cases. So then it means that there are other factors that are yet to be determined. So with that in mind, we used data from gene expression data and metabolomics data from the Emory Health Predictive Institute to identify genes that are associated with metabolites or metabolomic features, and that can discriminate between patients at high versus low risk for ACHD. We had data on 142 patients, and we also incorporated clinical or demographic data such as age, LDL, and triglycerides. Next slide, please. So that we use the method that we have developed in-house. And we have multiple methods we have developed, but I'll focus on just one method that we use in this particular application. And that method is called SIDA and SIDANet. So SIDA is short for Sparse Integrated Discriminant Analysis. So the purpose of this method is to integrate data from multiple sources and to simultaneously separate or discriminate between groups. So this is a dimension reduction method, and dimension reduction is important because if you have a lot of variables, there is you can just imagine searching for a signal in a stack of hay. So then you need to have methods that could reduce the noise or eliminate the noise and be able to identify the signals. So this particular method is able to reduce the dimension, is able to screen unimportant variables, and it is a multi-class classification approach. If you were to use this method, you get some nice visuals, you get discriminant plot, you get correlation plot, and importantly, you are able to identify biomarkers for further analyses. Next slide, please. So using this method, we identified a panel of 28 genes that, when added to age and gender, was highly predictive of risk for CHD. We noticed that for AUC, the AUC of just for age and gender in the model was just 0.79. But then when we added the genes, the 28 genes that were developed into a score to the model, the AUC increased from 0.79 to 0.94. When we added the metabolomic features, the 7 metabolomic features that were identified by the method to the model, the AUC increased to 0.87. So this shows the benefit of adding other factors or going beyond clinical factors such as age and gender in your model. Next slide, please. In summary, the promise of systems biology for public health is enormous. I've only demonstrated one case use. In our work, we have used multi-view methods to identify COPD subtypes. We have also used multi-view methods to better understand COVID-19. But then one needs to be aware of the study design, analytic, and interpretative challenges when integrating data from multiple sources. If you are interested in knowing more about our work, please visit my website. If you are learning, if you want to use multi-omics methods in your next work, you can send me an email and then we can chat. Thank you.
Sandra, thank you so much for a really wonderful presentation. And I certainly appreciate the offer to consult with others who are interested in this methodology. So again, look forward to talking more during the Q&A. Now we will tour back and go back into the Division of Epi and Community Health. I'm really pleased to introduce Dr. Kumi Smith, who's an assistant professor. The title of her talk is Healthcare Stigma, with an incognito patient approach. Kumi.
Thanks, Marison, and thanks to everyone for this chance to share with you some research that my team and I have been conducting on stigma in healthcare settings, and we use an incognito patient approach, which I'll tell you about. Next slide, please. So stigma is a social process by which certain groups are labeled or stereotyped, and it results in discrimination in all kinds of places like schools, workplaces, and healthcare settings. But we focus on the healthcare setting because when it happens there, it means people are getting turned away or mistreated when they're most in need of help, that is, when they're unwell. Next slide, please. Worse still is that the people who we find face the most healthcare stigma are often those with specialized health needs. People living with HIV, for example, need regular medical care to stay healthy. Or men who have sex with men, or MSM, are another key group because they face higher burdens of HIV and STIs, and they can benefit from regular screening. Of course, there's also people who may occupy both of these identities and face what we call intersectional stigma. So these negative experiences in healthcare settings means we're not getting, these folks are not getting the care that they need, and that we in public health are missing valuable opportunities to provide important prevention counseling. It's therefore imperative to figure out how and why this stigma happens so we can start to address it. Next slide, please. But one of the biggest barriers to doing this is measurement. As the old adage goes, it's impossible to change what you can't measure. So to understand this challenge of measurement in the context of healthcare stigma, consider the two most common sources of information we have on the problem, doctors and patients, or in stigma parlance, the enactor and the victim. Next slide. If we ask doctors to tell us what's happening in their patient encounters, they have a pretty strong and understandable incentive not to tell us the entire truth. Another way to think of this is what we call social desirability bias. Next. But if we ask patients, we don't have any reason to necessarily question their truthfulness, but there's a ton of information asymmetry between doctors and patients. So it can be challenging for patients to tell if they're getting the appropriate care. Also, if that patient occupies more than one stigmatized identity, it may be a lot to ask them to determine whether the poor treatment they got is because of, say, their race versus because of their gender. Next. So a potential solution could be to introduce a neutral third observer who witnesses and reports on the patient-provider encounter. But we know from experience that clinicians under observation will alter their behaviors. This is the phenomenon known as the Hawthorne effect. Next. So the solution we've developed in this study is to supplant the patient with the third-party observer. Next. So what's happening here is that the person is assuming a role of both patient and observer at once. And this is achieved with a technique that we call the unannounced standardized patient visit. Next. Next slide, please. Next one. So this technique borrows from the long tradition in medical education of working with standardized patients, or SPs, who are trained actors who specialize in role play and give constructive feedback to medical learners. This type of training usually happens in simulation settings like the one pictured here, where everyone knows that this is a staged encounter. Next. But in our study, which takes place in Guangzhou, China, our standardized patients, or SPs, instead conduct unannounced visits. So they visit doctors in their actual clinics where we can glimpse how stigma unfolds in the real world. We only conduct visits with providers who consent to it in advance, but they're not told when the visit will happen. Our SPs are recruited from the local LGBTQIA+ community, and they undergo extensive training to ensure that they know how to present a standardized case, how to objectively observe doctors, and how to do so while protecting their own and the doctor's safety. Next. Then over the course of repeated SP visits, we randomly vary both the sexual orientation and the HIV status of the presented cases. This allows us to compare the quality of care that SPs are reporting back to us when they present either as a person living with HIV, a person who is reporting same-sex behaviors, or a person with both of these traits. So when you compare each of these three stigmatized identities with the referent case, this allows us to separately quantify HIV stigma, homophobia, and their intersection. Next slide. And we measure this quality of care with a really extensive checklist. This is just the first of many pages that SPs are asked to fill out after each clinic visit. Items track provider behaviors across a number of the domains listed here that are considered important to patients in the LGBTQIA+ community and the HIV positive community. Next slide. But we, of course, don't want to just sit back and watch stigma happen. We want to use these insights to build interventions that can address it. So that's exactly what we did with the help of our 2 advisory boards in Guangzhou, one made up of doctors and the other made up of MSM and people living with HIV. Next slide. So with their help, we have designed a 2-day stigma reduction intervention. And since these activities are taking part in the context of an NIH-funded pilot RCT, half of our doctors received this training just this past winter. And we have just started now doing follow-up SP visits, results of which will tell us whether these trainings can make a real difference for patients in the HIV positive and LGBTQIA+ communities. Next slide. So I thank you from our Guangzhou-based study team and our amazing ST crew, and look forward to questions in the Q&A session. Thank you.
Thank you so much, Kumi. And I think this is our final lightning round speaker. And I'm pleased to present Dr. David Vok, who's an associate professor in the Division of Biostatistics. And now he will be discussing the design, implementation, and analysis of clinical trials related to COVID-19 therapeutics. David?
Great. Well, thank you, Dr. Ramirez, for that nice introduction. Yeah, so I want to give just a little bit of background of COVID clinical trials as they were sort of starting in the early days of the pandemic. So shortly after the pandemic started in spring of 2020, NIH organized itself into the active clinical trials. Active stands for accelerating COVID-19 therapeutic interventions and vaccines. They looked at a variety of different areas that they thought different therapeutics might make a difference. The Coordinating Centers for Biometric Research, led by my colleague Jim Neaton, we were tasked with designing, implementing, and analyzing trials related to inpatient monoclonal antibodies and other therapies. And so we were tasked very early on in the pandemic with designing these trials in hopes of understanding the effects of monoclonal antibodies or MABs in the context of hospitalized patients. Next slide. And so, also around this time, a meme started circulating around on Stats Twitter or Biostats Twitter. I'm sure all of you comb that on a near nightly basis like I do. And so it emphasized the need for having, good study design, because bad study design, often cannot be overcome even with really fancy, statistics. Next slide. And so, of course, this begs the question, what is good study design and what is bad study design? And of course, I've never had a collaborator come to me and say, I want the bad study design. But what I think people often miss here when we're talking about study design is much like any other intervention that I've talked with my colleagues in SPH about, is that context matters. So for example, I often talk with my colleagues, and they will often tell me how when an intervention is delivered, how effective it is depends on the cultural context in which it's delivered. It depends on whether it's delivered in a high resource or a low resource environment. And the thing that I want to emphasize most in this talk right here is that anytime you have a normative understanding like good study design or bad study design, that is also going to be highly context dependent. Next slide, please. And I also want to emphasize here that I probably don't need to say this, but the context dramatically changed when we're talking about a viral pandemic. And so, none of this was normal. And if you think about the work that I have typically done in my time on the faculty here at SPH, is, I've usually worked on clinical trials that face, immense budget constraints, where we have a long time to do the conception, the design, the analysis, the execution, and all of that. We typically enrolled a modest number of people. I tended to work a lot in non-pharmacologic interventions, with a very small group of statisticians, usually me, maybe perhaps me and a graduate student. And COVID changed the context of this all very dramatically. We were in a situation where we needed to move incredibly quickly. We needed to enroll a lot of people because we wanted to understand the effect of the intervention very quickly. And we were willing to jettison somewhat promising interventions quickly if we thought that there was a better one out there. And so I want to talk just a little bit about how COVID in particular changed what we valued in study design. So as I mentioned, we needed to enroll really, really quickly. In other words, we needed to get hospitalized patients to consent to be randomized to receive a monoclonal antibody or a placebo. And it's very difficult to get studies up and started in hospitalized patients, particularly in a setting where hospitals were very, very taxed with a high patient burden. And so this led us to partner with several clinical trial networks. So prior to the pandemic, NIH had long supported various networks of academic medical centers and community-based hospitals to work together to implement various clinical trials. So the Insight Network was a long-standing one that was led by my colleague, Jim Neaton. And we partnered with other clinical trial networks, the Cardiothoracic Surgeon Trials Network, or CTSN, the PEDAL Network, which looked at was an acute lung injury clinical trial network, as a way of getting us to enroll patients more quickly. So bringing together multiple trial networks, which we had really never done before. This was a particular COVID necessity. Next slide, please. You know, we also needed to think about, when we were designing the trial, what were we going to measure here? And that's often known as the endpoint of the trial. And so a lot of times people really like to work with binary endpoints. So to look at, 30 days after a patient gets their medication, are they alive or dead? That's a very interpretable and understandable endpoint that we can explain to a wide audience. But the problem with binary endpoints is that they lack granularity. You're either alive or you're dead. There's not a lot of nuance to the patient well-being in between those two categories. And one implication of that is that significantly reduces our power to detect a significant difference. And that causes us to need a much larger sample size, which we didn't want to do. And so we needed to innovate and come up with more granular measures of patient well-being that have better power. Next slide. And so one of the things that my colleagues and I had been working on in the context of influenza that we were able to apply quickly to COVID was to use an ordinal measure of patient well-being. So rather than just look at alive or dead, we had developed this scale, a very similar scale in the context of influenza, and adapted it to COVID, where we look at things like oxygen burden and organ dysfunction to more granularly measure patient outcomes. Next slide. The other thing that we need to do is we need to think about efficient design and allocation. So one of the things that we wanted to reduce was the number of patients who were assigned a placebo group. And so as part of our group here, we've studied 5 different monoclonal antibodies that are listed here. One of the things that we did here is that rather than having each trial run separately in its own silo, those trials were run concurrently, and they were able to share a placebo group, and that reduced the number of participants that we needed to enroll to learn the same thing. Next slide, please. And this is a schematic. At one time, we had 3 drugs going at the same time, and they all shared a placebo group, reducing the number of people that we needed. Next slide. The last thing that I just want to briefly mention is that we needed to think about ways of jettisoning inefficient therapies. And so we needed to think about ways in which we could close studies down quickly that weren't showing any promise. And the problem is that a lot of times we were looking at endpoints that might be assessed at a very long, over a long prolonged period of time, like time to sustain recovery. And so we innovated and came up with ways of looking at more intermediate endpoints. How well are you doing 5 days after randomization, as a way of assessing how well the therapies were doing. Next slide, please. And so, I just want to conclude here that a mantra that I tell myself on a near daily basis is that the trial or the research product or the lecture or whatever I'm doing that is successfully completed is infinitely times better than the perfect trial that is never started, or in the context of a pandemic, started months later, as time was of the essence. But good trial design is also context dependent, and that context changes a lot during a pandemic. So I'll leave this right here, and I'll be happy to take any questions during the Q&A. We can just go to the last slide there.
Thank you so much, David. Were those the papers that have been published so quickly after during your studies? I'm just curious, that last slide there. Oh,
Was that a question? Yeah, those were some of the
Yeah.
studies that we've been able to do on both the method side and then the analysis of the
Yeah,
data.
yeah.
So,
Well, thank you so much, David. We'll definitely have questions for you during the Q&A. But now I'd like to turn the mic over to Sarah Veblen Mortensen. She's our Director of Research Initiatives, and she will present the Best Student Poster Awards and the presentation. After that piece is done, we'll come back and have the Q&A that includes both our student awardees and our faculty and other students who have presented here during the lightning rounds. So Sarah.
Thank you, Marizan. Hello, everyone. So of course, our lightning round speakers, thank you very much, are a key component of our SPH Research Day, but certainly another key and important component is the showcasing of our student scholarship with our abstract and poster submissions, which, as most of you probably know, can be viewed on our Canvas Student Gallery. And we absolutely invite you, if you haven't had a chance to go look at these amazing posters, to go there. We had 26 abstract and posters submitted this year. We think that that is a record number. Thank you to all the students for their quality work, their responsiveness and communication. It was really a pleasure to review your posters, and we encourage the whole community and of course everyone here to go to that poster gallery. Once again, we're going to post that link in the chat, and we'll also have it on our very last slide, so you can go and spend some other time this week or next week viewing those posters. So our SPH Research Days follows the judging guidelines for student poster awarding set forth by the APHA and Delta Omega for its national poster competition. So each student abstract and poster was rated in 8 categories by a panel of faculty and alumni and judges, and thanks to them, things like topic prominence, presentation objectives, purpose, practice impact, academic impact, originality, tone, and overall. So the top 3 scores in both the PhD and master's categories were awarded first, second, and third place for the Best Student Poster Award competition. And we also had a People's Choice top 3 awards as well. So now it's my pleasure to announce the People's Choice Awards and the Best Student Poster Awards. So voting for the People's Choice Awards took place over the last week when the gallery opened on Monday, and people who went to view were asked to select their first, second, and third choice winners. So here they are. So in first place, the title of this poster was Governance Structure Affects Transboundary Disease Management Under Alternative Objectives by Mihailo Malehov. In second place, we had a tie here. The first title was Alcohol Use Among LGBTQ+ Adults Experiencing Unmet Mental Health Care During the COVID-19 Pandemic, Cross-Sectional Data Analysis from 2020 by Annie Youngblood. And then secondly, Ukraine's Health System in Transition Under Attack by Maya Benedict. And our third place People's Choice, the title of that poster was Wildfires and Mental Health, the Impact of Indirect Exposure to a Climate-Induced Disaster by Caitlin Varquez. So congratulations to all of those People's Choice Awards. That's quite an honor. All right, so let's move on then to our poster award winners. So our congratulation goes to Paige Richmond for her third place winning poster in the master's level category. Paige is a master's student in the epidemiology program, and the title of her poster is Differences in Treatment Outcomes for Opioid Use Disorder Between Pregnant and Non-Pregnant Females in the United States, 2019. Congratulations, Paige. Our congratulations go to Joseph Amkambase for his second place winning poster in the master's category. Joseph is in our epidemiology program, and the title of his poster is The Effect of Anthelminthic Treatment on Malaria Prevalence, a secondary data analysis of the Susandenga malaria study. Congratulations goes to Joseph. And our congratulations goes to Alexandra Alcheva for her third place winning poster in the PhD level category. Alexandra is in the environmental health program, and the title of her poster is Relationship Between Oral Microbiome and Tobacco-Associated Oral Cell DNA Damage in Smokers with Known Differences in Health Risk. Congratulations, Alexandra. And then our congratulations go once again to Mihailo Malehov for a second place winning poster in the PhD category. Mihailo is in our biostatistics Biostatistics program, and the title of his poster is Governance Structure Affects Transboundary Disease Management Under Alternative Objectives. So congratulations to our third and second place poster award winners. And I hope, again, all will go to see these incredible posters. All right, now our first place poster winners, we'll turn it back to Marizan because she's going to walk us through these poster winners, and then they'll be giving their presentations. So first up will be Claire Huber, who's our first place winner in the master's category. She's in the maternal and child health program, and the title of her poster and what will be presentation here is Exploring Associations Between Adolescent Intimate Partner Violence and Contraceptive Use.
Wonderful, Claire. We're really happy to have you here. Congratulations on receiving the award. And as everyone knows, our first place awardees have the opportunity to present their work. So Claire, the mic is yours.
Thank you. And thank you so much for having me. And thank you to everyone for being here. As they mentioned, I just want to start by saying my research is about intimate partner violence and contraceptive use among adolescents. So that's pretty sensitive and just a lot of heavy topics all at once. And these things are hard to talk about, so sometimes we just don't talk about them. But as sensitive as it is, I think that they're really important topics. So I just want to take you all with me as we bring them to the forefront. Next slide, please. Before I started my program here, I worked at a crisis shelter in Kentucky, where we worked with people who had experienced intimate partner violence. So that includes physical, sexual, verbal, or psychological abuse in an intimate relationship. And something that really got to me in this work was how many times I would pick up the phone and there was a kid on the other line. We would talk to 12-year-olds and 16-year-olds about these tough things that I so naively thought were just adult problems. So here's what we know. 36% of women and 34% of males experience intimate partner violence in their lifetimes. So I want to ask you for some engagement. Out of all the females who experience intimate partner violence, what percentage of them do you think first experienced intimate partner violence before they were 18 years old? So you can put it in the chat or the Q&A. I'll give you a few seconds. Okay, thank you all. I see between 10%, 80%, in the 60s, all over the place. So next slide, please. 26% of female victims of IPV report that they first experienced IPV before age 18. So that's 1 in 12 adolescents who will experience IPV at some point in their lifetime. With everything else going on in middle school and high school, you think about sports and jobs and friendships and relationships. 1 in 12 kids are also experiencing intimate partner violence, which is sometimes referred to as teen dating violence. Now that we know this, where do we go from here? And what does this mean for adolescents? I have one more question for you. What do you all think are some of the effects of dating violence and intimate partner violence in adolescence? Again, I'll give you a few seconds to put it in the chat. Okay, thank you all. I see some anxiety and depression, so mental health concerns, eating disorders, suicidal ideation. Next slide, please. So you guys are right, mental health concerns is one of the major effects of adolescent intimate partner violence. And other things that have been associated with adolescent IPV are increased risk for substance use. I see teen pregnancy in there, that's right, so the mistimed pregnancies. Adolescents who experience IPV have a higher risk of experiencing IPV in adulthood. And adolescents who experience IPV have the higher risk for mistimed pregnancies and sexually transmitted infections. Being in maternal and child health and sexual health, that's something that piqued my interest. Why are STI and mistimed pregnancy rates higher in adolescents who are experiencing IPV? Sometimes this could be due to reproductive coercion, which is when someone in an intimate relationship tries to use different methods to control or manipulate a partner's reproductive health decisions. There's been research that shows that adult women who experience IPV have a lack of contraceptive use or inconsistent contraceptive use because it's so difficult to negotiate using contraception with an abusive partner. This research, however, typically talks about adult women, and there's not as much research about adolescents and adolescents of all genders. Next slide, please. So this is where my research comes in. I wanted to look at if using contraception is impacted by an adolescent experiencing IPV. I also wondered if adolescents who have experienced IPV are less likely to use contraception. Maybe it's because they don't feel comfortable having conversations about safer sex with their partners. So I added that to my hypothesis too. I wanted to make sure also that I looked at multiple genders in addition to females, as I thought that this might impact both intimate partner violence and contraceptive use. Next slide, please. So I performed a secondary data analysis using an outside data set, the Minnesota Student Survey from 2019 for my analysis. The Minnesota Student Survey is a cross-sectional self-reported survey that's given to 5th, 8th, 9th, and 11th grade students in Minnesota. In 2019, there were over 170,000 students who completed the survey. But for my research, I needed students who were asked questions about sexual health, which was just 9th and 11th graders. I looked at students who were sexually active and students who had responded to questions about healthy relationships, contraceptive use, and gender. So this left me with 13,978 students. Next slide, please. So here's a look at our study sample. This shows the frequency of each group of the population that reported intimate partner violence and the frequency that reported no contraceptive use. So I'm going to give you a few seconds to look at that and take that in. So what stood out to me when looking at this was that in our study population of sexually active adolescents, over 50% of non-binary students and gender other or unsure students reported some form of intimate partner violence. So that could include verbal, sexual, or physical violence. Out of our whole study population, almost 35% of students reported some form of intimate partner violence, and almost 8% of students reported no contraceptive use. Next slide, please. So going back to those safer sex conversations, I thought that adolescents who were experiencing IPV would be less likely to talk to their partners about safer sex, which would decrease their contraceptive use. Here you can see that the frequencies of safer sex conversations were actually really similar in students who had experienced IPV and students who had not. But you can see too that the frequency of safer sex conversations was higher among those who used contraception than those who didn't. And this is what I found with my statistical analysis too. Having safer sex conversations was predictive of positive contraceptive use, but experiencing IPV was not significantly predictive of having those safer sex conversations. So there has to be another mechanism in place that's causing the results that I see. Next slide, please. Because what I found overall was that adolescents who experience IPV have significantly lower odds of contraceptive use than adolescents who have not experienced IPV. Among adolescents who experienced IPV, females had the highest odds of contraceptive use compared to the other genders, and non-binary and gender other or unsure students had significantly lower odds of contraceptive use compared to males and females who had experienced IPV. I looked at the different types of intimate partner violence that adolescents had experienced, and those who experienced physical IPV had the lowest odds of contraceptive use compared to those who had experienced sexual or verbal IPV. So this means that there could be some reproductive coercion happening in adolescent relationships, which has been found in previous research, or adolescents who are in violent relationships have safety concerns that outweigh trying to negotiate contraceptive use, which has been found in similar research with adult women. Next slide, please. So where do we go from here? We need to look at more inclusive measures of sexual health. Using contraception is not a comprehensive measure of sexual health. Many other things impact adolescents' contraceptive use, such as poor sexual health education or lack of access to contraception, especially among adolescents who are experiencing physical IPV. We know that gender nonconforming youth, such as non-binary youth, often experience sexual health education or sexual health resources that are not inclusive or respectful of their identities and their specific needs. We need more research specifically engaging with gender nonconforming youth about the sexual health barriers that they face if they're experiencing IPV. If what's found in this study is supported by further more expansive research, it could suggest targeting IPV reduction as a way to address adolescent contraceptive use. Next slide, please. So I want to leave you with this. When I worked at the crisis shelter in Kentucky, we used to always say, I hope we work ourselves out of a job. I hope our shelter's empty and our phone lines are free. And I still feel that way today. I hope that eventually I can no longer do this type of research because no more adolescents are experiencing IPV. And I hope that this is a vision that you share with me, that someday all youth will feel safe in their relationships. And we get there by talking about it and engaging with youth to understand the issue and how we can prevent it. So I want to thank you for joining me in this conversation today. And I want to especially thank Dr. Nancy Sherwood and Dr. Simon Rosser, who served as my advisors for this research. And I invite you, if you have any questions, to engage in the Q&A or engage with my research poster online, or you can email me. So thank you again.
Thank you so much, Claire. What an engaging presentation you had today. Again, congratulations for your first place award. And so I believe this is our last speaker for today, and I'm pleased to present Ms. Keely Morris. She is our first place winner in the PhD category for Best Poster. She comes from us from the Division of Epidemiology, and the title of her presentation is Potential Mechanisms for Pandemic Fatigue, the time-varying relationship between stress and average contacts in the COVID-19 pandemic. Keely.
Thank you, Dean Ramirez. And I think as soon as you stop sharing your screen, I'll be able to share mine. Perfect. Great. Thank you, everyone. So I'm going to talk today about a research study that's actually in process. We are specifically beginning to dig in a little bit into this concept of pandemic fatigue. And the study that I'm working on is specifically looking at the time varying relationship between the psychological measure of stress and an individual's average number of contacts during an early part of the COVID-19 pandemic. I conduct this work alongside Dr. Jillian Tarr, as well as several other members of the COVID-19 preparedness and response research team. So pretty much from the very beginning of the COVID-19 pandemic, there were measures being implemented aimed at reducing person-to-person interactions. All of us are probably very familiar with the Stop the Spread or Flatten the Curve campaigns. These measures included things like the issuance of stay-at-home orders or lockdowns, closure of non-essential businesses, capacity restrictions on businesses that remained open, as well as recommendations for individuals to limit their outings and interactions with people outside their households. And it might be really difficult to imagine this now, but there actually was pretty uniform agreement about the importance of social distancing measures in the beginning of the pandemic. This study that I'm sharing here on the screen is a nationally representative sample of 35,000 US adults that collected information across 3 waves, April of 2020, July of 2020, and November of 2020. And you can see here that there is pretty substantial support for social distancing as an important measure for stopping the spread of COVID-19, with between 75 and 85% of respondents identifying it as being important. And it was the highest ranked measure in the survey. Yet despite this general support and belief in its effectiveness in the early pandemic, we did witness a demotivation to adhere to these physical distancing recommendations, even in the early months of COVID-19. The study that I'm presenting some images on the right shows the contact patterns and the movement of individuals between counties in the United States. March 2nd through the 8th is sort of early in the pandemic. It's around the point in time, for those of you who might remember, that we detected our first case of COVID-19 in Minnesota. But this is really before many of the lockdowns occurred across the United States. And you can see that there's pretty substantial movement between counties. That has changed significantly approximately a month later in the April 6th to 12th timeframe. Between the first time period and the second time period, the president had declared a nationwide emergency. The first major shutdowns began to occur in the United States beginning March 15th. And within that week, this was the time point that the US surpassed Italy as the global leader for COVID-19 deaths, which Italy had up until that point been the peak of the outbreak, COVID-19 outbreak at that time. You can see here that over time, however, the movements began to increase across the United States, even just a month later and going into the end of May 2020. And this was despite the fact that many parts of the United States were still experiencing increasing number of cases and mortality, and many states still had stay-at-home orders and business capacity restrictions in place. It's also around this point in time that we began the COVID-19 preparedness and response study. The aim of our study was to examine how early pandemic preparations, as well as external stressors, health beliefs, and community characteristics might impact individuals' protective behaviors, such as how often they left their home, how frequently they had close interactions with non-household members, and whether or not they chose to use masks. To achieve this objective, we enrolled 2 cohorts of people that we identified as being at increased risk for potential significant impact during the COVID-19 pandemic. Our first cohort consisted of 1,001 adults, 1,001 families with children from Minnesota and Iowa. We chose families with children because we imagined that households that were trying to navigate children being home from school and adults transitioning to a work-at-home environment might experience increased stress and difficulty managing a household at this time. In addition, households with children were probably more likely to need to obtain resources from essential businesses that would be open. So we chose to focus first on this group. And then we also chose to enroll a second cohort of 340 adults over age 50. These adults were from Minnesota only and were part of an existing cohort looking at some impacts of Parkinson's disease. So 1/3 of the adults in this population have Parkinson's disease. And we chose to enroll older adults because older adults experience greater severe outcomes from COVID-19, which is something that we had already identified early in the pandemic. We collected a pretty wide variety of information, primarily via online survey, about things like household demographics, household composition. I mentioned those health beliefs, including self-efficacy and people's disease risk and severity perceptions. One of the primary exposure for the study I'm going to talk about today was a measure of stress using the Kessler-6 scale, and we collected other measures of physical and mental health. And then the primary outcome in the study I'm going to talk about today was related to outings, contacts, and visitors to the home. We measured contacts and visitors as any sort of encounter that occurred at less than 6 feet. At this point in time of the pandemic, we hadn't really zeroed in on that 15-minute time frame that was really popular. And we weren't necessarily interested in measuring like sufficient exposure duration of time, because we know that people's recall for the amount of time that they're exposed to an individual isn't great. So we just focused on those less than 6 feet encounters. Oh, and just briefly, we collected 6 surveys from April 2020 through September 2020. So I want to talk a little bit about pandemic fatigue. Pandemic fatigue is something that emerged early in the pandemic, but we didn't necessarily have great language to talk about it. The phenomena itself is common among people who experience high levels of trauma, as might occur during pandemics. And the WHO issued a really useful report that talks a little bit about what pandemic fatigue really is. They define it as a behavior that expresses itself as an emerging demotivation to engage in protective behaviors or to seek COVID-19 COVID-19 related information. And I think a really important piece here, it's common because of the term pandemic fatigue. People often think of this as like a form of exhaustion or a negative reaction to the pandemic, but often it just manifests itself as a complacency, like a sense of normalcy of the way that things are. So it's important to keep complacency in mind, but it can also manifest as feelings of alienation and hopelessness. It's also helpful to think of pandemic fatigue as this interrelationship between these two factors. People experience a decrease in their perception of the threat from COVID-19 as they begin to get used to its existence in their day-to-day lives, while simultaneously experiencing an increase in their perceived loss as a result of the pandemic restrictions. The WHO developed a framework for thinking about pandemic fatigue, and it's based off of the COM-B model for change in behavior. The COM-B model theorizes that there must be 3 factors present in order for a behavior to occur. These factors fall loosely into the categories of capability, opportunity, and motivation. And I know this image is kind of small, but you can see that motivation is where the WHO has centered their concept of fatigue. And then they have other factors of opportunity and capability that interrelate with one another to motivate individuals to engage in protective behaviors. We recognized that because our study had collected information about individuals from the same individuals over the first 6 months of the pandemic, we had an opportunity to potentially investigate pandemic fatigue during this time period a little further. And so what I'm showing here is our adapted COM-B model that's based off of the WHO framework, but specifically is looking at variables that we collected as part of the COVID-19 preparedness and response study. We have 2 primary pathways: the pathway of opportunity through the motivation of engaging in protective behaviors. And then our outcome here is those average weekly non-household and non-work contacts. That first pathway of opportunity, motivation, and behavior was investigated by another person on our study team, Damon Leach, who's a Master's of Biostat student who has now graduated, worked with his advisor, Dr. Mark Ficus, on looking at socioeconomic factors, which we considered to be part of that opportunity category. And he found that socioeconomic factors such as age, gender, race, and education were all associated with change in average weekly contacts across time. Importantly, he also found that age and education were factors that modified the association between week and average contacts. And you can see a sample of his study results in the image here, showing that depending on a person's underlying education level, their patterns of contact behaviors did change over time. This provides some evidence that there is a relationship between opportunity variables and physical distancing behaviors, which according to our framework, we hypothesize as being via this demotivation pathway. One important thing to note is that while the COM-B model theorizes motivation as an element of the framework, we've chosen to use demotivation here to align with the definition for pandemic fatigue. The study that I worked on is looking at this capability capability variables as a primary exposure, and similarly looking at this pathway between demotivation and behavior. As I mentioned, stress was the primary factor that we were interested in looking to. And in our early analysis, we examined whether there were distinct relationships between stress and average weekly contacts across time. You can see from the graph here that we identified 3 patterns of this relationship. The first pattern occurs during the April 16th to April 30th timeframe, which is roughly corresponding with the first stay-at-home order in Minnesota. Then we observed a non-monotonic relationship for the period from May 1st to June 30th, followed by a strong negative linear relationship from July 1st to October 11th. From this, we interpret that there is a variation in the stress behavior relationship across different points of the pandemic. And as I mentioned, this is a study in progress, so our next steps are going to be to further examine the associations between stress, confounders, and average weekly contacts using marginal structural models. You can see from the sample DAG here that stress is a factor that varies across our survey time points. Stress is affected by confounders that also vary across time, and that prior stress and prior contacts are, we believe, associated with some of those time-varying confounders at later time points. When you have time-varying confounding in this way, traditional regression methods would be biased. So we're going to use marginal structural models, which employ inverse probability weighting to create a pseudo population that's absent of confounding from these time varying confounders. So in conclusion, we developed a conceptual model to examine pandemic fatigue in a cohort of families with children and older adults during the first 6 months of the COVID-19 pandemic. Prior analysis and some preliminary examination did provide evidence that there is a changing relationship across time between our various predictors and average weekly contacts. And our future analysis is going to examine those relationships in more detail using marginal structural models to account for time varying relationships. And we envision that these results will provide areas of focus for policymakers in order to help them maximize efforts to reduce pandemic fatigue, both during the COVID-19 as well as future outbreaks. Thank you. And if happy to take questions during the Q&A or via email if anybody has anything else they'd like to ask. And a special thanks to the COVID-19 Preparedness and Response Study team.
Keely, thank you so much for your wonderful presentation. And at this time, I want to open up the panel here for Q&A. So if anybody has any additional Q&A questions, make sure you enter that either into the chat or use that Q&A function button. So I will begin with a couple of questions that were asked a little bit earlier on. So let's get back to Dana. And Dana's presentation examined cigarettes and removing nicotine from cigarettes as a potential approach for intervening on fatalities. And that was 8.5 million fatalities. Is that correct? Okay. So Dana, we had a comment in the chat. Really liked your presentation. Is it also being studied how to remove tar from cigarettes?
Yeah, thank you for that question. I think it seems that that would be a more obvious target than nicotine, because tar is what can contribute to some of the devastating effects of cigarettes. So when the cigarette burns, it creates a composition of chemicals, including which goes on to be tar. And so there's a lot of chemicals in tar that make it challenging to just target versus having the one target of nicotine. In fact, I do not believe that you can not have a cigarette without tar because of the burning and the combustion. So the approach of reducing nicotine is one where, again, it's one chemical in the cigarette that can serve as a target that is potentially more feasible and practical. I will say there are other avenues being studied beyond just nicotine for reducing the addictiveness and appeal. Another direction that I've done some work in is around filter ventilation. So filters were added to cigarettes, then ventilation was added to cigarettes to make it seem that cigarettes are less harmful. And we have shown work showing that that is not the case, and yet there's a misperception that they are less harmful if they have ventilation. So when the public has a misperception, it's our responsibility in public health to help correct that. So we're working on efforts to do that, and that could include actually removing filter ventilation because it doesn't have a benefit to public health. Thank you for your question.
Thank you so much, Dana. What a great kind of concept that all of these strategies are being utilized, sort of simultaneously. All right. I wanted to ask Ryan a question. So, obviously with long COVID, there are you showed the diversity of various kinds of outcomes that are potentially of concern. Is there one that's sort of the leading, a leading outcome of concern that has raised raised eyebrows, and what kind of work is being done to address that particular long COVID illness?
Thanks for the question. There are several. I think the two most prominent, you asked for one, and if I had to say one, probably the one that gets the most attention is cognitive decline in dementias. There's a lot of recent data on that. These are very hard constructs to measure, and I think we need much better and more careful research to be sure that these cognitive deficits are actually emerging as a result of SARS-CoV-2 and not over-detected in people with prior infection. Because the big problem with this is that it's becoming a diagnosis of exclusion. And there's a lot of assumption about causality before we have the data. But I would say the dementias is the #1 outcome. Another one that can be measured a little bit more objectively is cardiovascular disease. Cardiovascular disease is the leading cause of death already. It tends to make people more susceptible to becoming infected. And there are a couple of recent studies coming out of really large EHR databases that have a few limitations, but overall very strongly, I thought, showed increased risk for almost any cardiovascular outcome you look at within roughly a year following a COVID infection. So that's not in the acute phase. They looked at 1 month to 1 year. So CVD and dementias would be the top two with the most focus at the moment.
Thank you so much, Ryan. And that point about measurement, I mean, obviously very important for the cognitive issues, and we'll certainly keep an eye out for that in that research in the future. Mary, we have a recent question that popped up. So have you done any work investigating the presence of microplastics in healthy food versus non-healthy food? Or if you know of any of that research, so for instances in fresh fruits and vegetables. Cindy wonders how diet and the food environment might play into how much microplastics one consumes over time. Really great question.
Yeah, thank you for that. I was just typing an answer. This is faster. So, you know, as I said, we've only really started to intentionally examine human food and beverages since 2015. And that really wasn't that long ago. And so we've just started to find its presence in plants and fruits and vegetables. There was an Italian study that found that. So we're really quite on the frontier of this. I will say that there have been many studies that have looked at various types of foods, such as milk in Mexico. They looked at many different brands of milk. And there were studies that involve white wines that are capped with, synthetic tops and that sort of thing, and packaging, but nothing really that's looked at healthy versus non-healthy foods, because we're still very much just starting to explore this. But I imagine we'll probably see something like that. Yeah, great question.
Great
Thanks,
question.
Mary.
Thanks so much. Okay, so now Cindy, who I know you asked that particular question, and you looked at political participation in the cycle of inequity. So one question that came up is, you talked about quasi-experiments. I mean, this is such a really complex issue and very, very important, I think, historically, for what we need to do to address, systemic racism in our community and society. Do you have any thoughts of some of those kind of quasi-experiments? Like what might be the interventions that you might want to test in the future to address this issue in marginalized populations?
Yes. So just off the top of my head, I'm really interested in how living with health inequities may impact political participation. And so if we can try to investigate areas where I know that there are areas where we're building new hospitals. So if we can understand, okay, what are the health inequities that people have been experiencing, and how will building this new hospital in this community impact people? And then later, how does that impact their likelihood of political participation? And there is research showing that people's interaction with healthcare impacts their likelihood of political participation. So building a hospital in particular can be really impactful for people and their health and the other ways they can participate. There's also things like, if you're building a new grocery store in an area, I'd be really interested to understand how having a new grocery store in a community may impact people's food intake and their ability to get food, and which may actually give them more free time to be politically active if they're able to get their food more quickly and feel more nourished from it. So those are the types of things that I'd be interested in investigating.
That is fantastic. I think that concept of investing into the community and finding some impacts is going to be really exciting. So I really applaud you for the work that you are doing. Okay, Manka, really interesting. I think, you really talked about the importance of this qualitative work in working with African immigrants, just that engagement. So I was really struck by that. One question that came about, I really appreciated the examples that you shared about language used. It raises important questions about how our public health and healthcare workforce can engage better, and particularly potentially the role of media. So kind of thinking about that engagement, what is it that we can do as public health professionals here in the School of Public Health to engage more in that, in learning and working with our communities?
Thank you so much for the question. I think engagement is very critical when we're working with racial and ethnic minority communities and other minoritized communities. And what we found in the past is that there's been a lot of injustice done because we just go in and we don't do the work to build relationship, because engagement is not a one touch approach. We have to be in community for a long time. And the model that I really like that is for engagement is called the Engage model, that was done by Dr. Denny and colleagues. And this model really talks about, you get into the community, you network, then you give, and then you assess their readiness for research, and then you kind of go back again and give. And so it's this approach where you are in community for such a long time, which is very different from what we're used to, and also very different from what our grant funders and kind of the system is used to. The system is set up in such a way that we have to get those letters of support and then we go get the grant. But that is not what really works, or what I found that works in community. We have to be there for about a year or so for some of the groups that I'm working with before the community partner can give me a letter of support. And so as researchers and as public health professionals, we have to really begin to just be in community right now, even before we think about the grants that we're going to write maybe 5 or 10 years down the line. So we have to begin doing that work of engagement right now.
Thank you, Manka. I think that's really an important message. It takes a lot of time to build those relationships and the trust. So, important to do, and we need to invest in, our resources and our energies into building those relationships. I know that we're kind of close to time, so I'm just going to ask one more question. This is interesting, David. You talked about somewhat, is it adapted or adaptive trials, which, the world shifts and the studies shift as you move forward. And in this kind of real world pandemic, you talked about how, maybe what you might imagine as your ideal trial certainly takes shifts and turns. So what kind of lessons can you share with the audience as we, engage and continue to do these kinds of trials when the real world is shifting and we don't know where the pandemic is going? What tips can you provide, and what do you sort of see into the future as we move forward with this pandemic?
Well, thanks for the really interesting question. Very challenging to answer, I think, in less than an hour-long lecture. I think one of the things that really has emerged for me in the context of the pandemic is, one, the strong need for partnerships across the country and really across the globe. We don't know where or when the next hotspot is going to happen, but we need to be ready to capitalize on the situation and enroll people where the disease is spreading. I think the other thing that we have to be constantly mindful of is adaptation, both in the very technical sense in the clinical trial world, where we're changing the study design, but also just adaptation in terms of our assumptions of what has worked in the past in terms of how we recruit people, how we engage with them. All of that is changing, and we have to acknowledge that this is an incredibly challenging time, and willing to challenge our own prior understanding of how we did things in the past, that they may not be optimal going forward.
Thank you so much, David. And I just want to applaud you all, because the work that we've done, many of us have taken on new topics because of the pandemic, because of the George Floyd murder, because of now our focus on inequity. So I thank you again, all of our speakers today. Now I want to ask our interim dean, Tim Beebe to say some closing words, and then we'll call it a day in a few minutes.
Great, thanks. I mean, wow. I mean, I'm just struck by how awesome our research is, and how impactful it is. Many thanks to you all for the work that you do. Congratulations on the wonderful work that you have undertaken and displayed today. And congratulations to the students, you know, won the poster awards and the People's Choice Awards. So congratulations to you. Just a couple of observations that I jotted down. You know, I'm struck, and this may sound obvious, but you know, our work really does impact lives. It actually, at the individual level and at the population level, it saves lives, and human and non-human. So I think we have to remind ourselves that this isn't just some sort of arcane exercise. This has a tangible impact that's demonstrated today. You know, the types of, you know, we live every day our land grant mission of engaging stakeholders authentically, and translating our research to policy and practice, as opposed to just publishing something and put it on the shelf. We're responsive to the questions of the community, and we cycle back and impact the lives of the community. We're not satisfied with just describing. We are interventional. We want to change the human condition through interventions that bring about tangible change. And I think that that's a hallmark of the work that we do. Lastly, I'm particularly impressed with the work of the students. So our future is in great hands. The work that you're doing is just so impressive. Now, you know, when I retire, I'm going to sit back and watch this next generation of public health professionals and scholars continue to save the world. So thank you for all your work and your engagement. Special thanks to Marizan and Sarah for orchestrating this hootenanny and emceeing today. So thank you all for joining. Marizan, do you have any concluding comments?
We do have I think we have some gift cards perhaps that we, in a raffle. So Sarah Veblen-Mortensen is going to announce a couple of our student winners. Sorry, faculty, it's just for our students.
Yeah.
All right,
Just
Sarah.
briefly, well, we want to honor all of our students, and poster winners receive prizes, but we also did a drawing just to honor everyone's participation. So quickly, we want to make sure that all of these gift card winners know that they were drawn at random from everyone who submitted a poster. So thank you all for submitting posters. And we'll get those too. We'll be following up with students on all the prizes, et cetera.
Okay. And I just want to close with a special thank you to Sarah Veblen-Mortensen and Sarah Harris, our two Sarahs who worked really, really hard in putting this successful event together. Both of them are relatively new in their positions. So for them to tackle this on, we really, they deserve a really warm applause here. We also want to thank our communication partners who got our word out, presenters, students who submitted their work, faculty, alumni, judges, donors, and stakeholders attending, to the SPH Research Committee for their ideas and support of this event. We have Lewisburg, our colleagues who are engaged in governmental relations who are present here, the Minnesota Youth Council, who are high school students representing different parts of our state. So obviously we have many, many folks who are present here to learn more and more about SPH research. So I'm so glad that we took the time to reflect and celebrate our community's research. And I want to extend the invitation for you all to view our posters. There's a link at the end of today's presentation, so you can go on that link and see the beautiful posters that were developed. Congratulations to our really amazing students who do such hard work, and thanks to the support of faculty for advising and supporting these projects. And finally, I thank you again for coming today. The recording of the event will be shared with our SPH community and stakeholders, so keep an eye out for that.